Hello, my name's Laurie Heaps. I'm a researcher and acupuncturist living and working in Glasgow. In 2018, as part of my Masters in Acupuncture, I conducted a study into what dosages of acupuncture do UK acupuncturists use to treat endometriosis-related symptoms. I studied at the Northern College of Acupuncture and graduated as an acupuncturist in 2018. I now have a busy practice in Glasgow city centre and will shortly be opening my own clinic on the south side of Glasgow where I live. As an acupuncturist, I treat a wide variety of conditions. I love the variety of the work that being in a large city in Scotland offers me. I'm really looking forward to sharing my research findings with you today. Over the next 15 minutes, I am going to present my research looking at the dosages of acupuncture that acupuncturists in the UK use to treat symptoms related to endometriosis. So I'd like to start by giving a quick overview of what we know about endometriosis. It happens when endometrial tissue in the form of lesions are found outside the uterus and often in the pelvic cavity. It is a chronic condition. It has no known cure. We also know in the UK it takes on average 7.5 years to receive a diagnosis of endometriosis. It affects an estimated 10% of the population born with a uterus, and the symptoms can be wide-ranging. Women experience physical and emotional symptoms which may affect quality of life. Pelvic pain is a symptom that many women commonly experience. The reasons why some women develop endometriosis are not very well understood. Retrograde menstruation is commonly thought to be a cause, and recent research suggests that women with a heightened inflammatory response may be predisposed to developing endometriosis. Biomedicine interventions aren't always acceptable to women with endometriosis, which was one of the reasons for wanting to conduct this research. Recently, a multidisciplinary approach has been advocated by healthcare professionals, and that may include acupuncture. An early task in the research project was to define what was meant by acupuncture dosage. There isn't a definitive agreed checklist of components to guide this, either in research or clinical practice. It's quite common to find researchers defining the acupuncture dose to suit the purposes of the study being conducted. A study by Bauer et al. In 2020 found that there was very limited guidance on acupuncture dosage when treating chronic pain conditions like endometriosis. So, in the absence of any agreed components, I use the stricter 2010 guidelines. It's a comprehensive, recognised and high quality list of acupuncture components, and it was convenient to use. I selected 9 components from stricter, which were the acupuncture points used, the needle retention time, the needle response, in other words, Qi, twitch, the method of stimulating the needle, the number and frequency of treatments, the timing of the treatments relative to the menstrual cycle, the number of needles used, and the co-interventions used. I also asked respondents to rate how often they diagnose specific Chinese medicine patterns, which I listed when they treat endometriosis. So what did I do? First of all, I sent a link to an online questionnaire to members of the British Acupuncture Council, the Association of Traditional Chinese Medicine, and the British Medical Acupuncture Society via members' newsletters and emails. I analysed the questionnaire data. This was tier 1 of the study. And then I invited the people who'd responded to the questionnaire who self-identified as endometriosis experts and met a defined criteria to a one-off interview, one-to-one via Zoom. Because this was a mixed method study, It was important that the two types of data I collected, i.e. quantitative and qualitative, were linked and gave different perspectives in answering the research question. The Tier 1 questionnaire was online, so people could answer quickly over a 5-week period. Although I recognise that some people wouldn't engage with an online questionnaire, so it might rule some people out. The questionnaire had 13 mainly closed questions using multiple choice and Likert scale questions, which collected mainly quantitative ordinal data about the use of each component of acupuncture dosage. I also asked the respondents to rate the perception of how important each component was to the possible treatment outcomes. I held 7 Tier 2 interviews over 2.5 weeks to explore the Tier 1 data findings. From the questionnaire data, I pulled out 2 themes that I wanted to explore in the Tier 2 interviews. Firstly, components that my Tier 1 respondents thought were important for the outcomes of treatment. And secondly, the reasons why Tier 2 experts thought Tier 1 dosage choices had been made. The interview topic guide had 17 main questions, and we explored the answers given to collect rich qualitative data set that the Tier 1 questionnaire wasn't able to gather because it was mainly quantitative. So who actually responded? 47 people answered the questionnaire with an average of 15.2 years post-qualifying experience. They were mainly BACC members practicing TCM style of acupuncture. This presented a bias in the data, which may have reflected my own unconscious bias when designing the questionnaire. For instance, I had preset the available diagnostic information on the questionnaire as Zhang Fu patterns of disharmony, but not all respondents use these as a diagnostic explanatory model. In fact, the questionnaire revealed 6 different explanatory models which fit into a Chinese medicine or a biomedicine framework. These included traditional Chinese medicine, the 5 elements, Japanese style, including Toahari acupuncture, Dr. Tan balance method, bloodletting, and Western medicine segmental acupuncture. Because there were low numbers of respondents who weren't BACC members and don't practice a TCM style of acupuncture, I took the decision to group them together in non-BACC and non-TCM style groups, and I compared these groups with the dominant groups, which were BACC members and TCM style of acupuncture. 79% of Tier 1 questionnaire respondents said that the acupuncture points selected and the number and frequency of treatments given were either very important or important to the treatment outcomes for endometriosis. These findings agree with current research literature. The Tier 2 experts nuanced these findings. They said that 2 things improved the patient's capacity to respond to treatment, or getting enough treatment into people, as one expert put it. These 2 things were firstly, the acupuncturist's ability to successfully collect and interpret diagnostic information to select acupuncture points, and secondly, the acupuncturist's skill in communicating, building rapport, and trust. They also said these skills take time to develop, and they rely on the practitioner's ability to reflect and learn when they get it wrong. Acupuncture points shown here are ones which I found in my literature review in studies of acupuncture for endometriosis. Over half of the Tier 1 questionnaire respondents in my study said they frequently always selected 9 of these points, in particular spleen 6, liver 3, spleen 10, Ren 4, Ren 6, and stomach 36 were the most frequently selected. This suggests a core group of acupuncture points is used to treat endometriosis by the questionnaire respondents. But this is only part of the story, because the respondents in my study also listed another 56 acupuncture points that they frequently or always use to treat endometriosis patients. And this suggests that a wider range of acupuncture points are used in clinical practice than in research. In my study, the Tier 2 experts cited point actions, practitioner training, clinical experience, peer influence, and inclusion in textbooks as their reasons for the choices they made about which points to needle. And they also suggested that the skills and knowledge required to balance acupuncture points when treating endometriosis develops through clinical experience. Learning comes from patients, mistakes made, peers, training undertaken, reading and research. The treatment duration of 6 months was common for all questionnaire respondents, no matter what organisation they belonged to or what style of acupuncture they practiced. It was noticeable that only BACC members said they treat endometriosis patients for 9 and 12 months, while non-BACC members tended to say they treat over longer periods of time, which actually were often 9 months plus. 41.2% of Tier 1 respondents using the TCM style of acupuncture treat for an average of 6 months, and they identified patient commitment and cost as major barriers to long-term treatment. A theme emerged from the data of undertreatment or not treating enough is a problem. Finally, my study also found that the patient has an influence on the acupuncture dose given. And this was interesting because it isn't often discussed in the existing body of endometriosis research. Analysing the data regarding the timing of treatment, some practitioners found that getting patients to come for frequent treatments was problematic, and that may result in undertreatment. While 80.8% of Tier 1 questionnaire respondents said they treat endometriosis patients weekly, the Tier 2 experts questioned if this was enough to achieve the optimal dose that's advocated by Bauer et al. In their 2020 paper. In fact, one Tier 2 expert called weekly treatments by UK acupuncturists a cultural habit. Tier 2 experts said they prefer to treat each patient based on their goals along with diagnostic information, and they thought that informed and honest communication coming from an expert stance was crucial in providing patients with informed choice to achieve the outcomes they were looking for. The use of Chinese herbal medicine when treating endometriosis patients meant that the frequency of acupuncture treatments could be reduced for some respondents. One area of major difference I found between the questionnaire data and the interview data was the question of when to treat in the menstrual cycle to influence symptoms. 72.3% of the questionnaire respondents treat in the week before the period. But for the experts I interviewed, timing in the menstrual cycle is one factor to be considered alongside other diagnostic information, including tongue, pulse, case history, observation, patient experience, and feedback. The experts noted that patients can experience pain at any time during the menstrual cycle, and a treatment given at any stage during the cycle has the capacity to influence menstruation. One expert said, but endometriosis is not always the pelvic pain. It's so unpredictable. I don't know if it makes any sense that you need to treat it the week before the period. The questionnaire respondents said they use at least one co-intervention when treating endometriosis. Lifestyle advice was frequently or always given to 76.6% of patients, and it tended to focus on diet and emotional well-being. Targeted advice on reducing inflammation and pain management strategies were also offered. Questionnaire respondents use co-interventions flexibly, and this is based on their training and skills to vary the acupuncture dose. And for those respondents who also use Chinese herbal medicine, the deeper actions of the herbs meant better results are achieved in a shorter time frame. So what are the implications of my research for clinical practice? I found that a very wide range of influences affect the acupuncture dose. These were most often practitioners' training, CPD, and clinical experience, but other factors, including the acupuncturist's ability to reflect on treatments given, collection and re-examination of diagnostic information, the ability to clearly communicate a professional opinion, and the capacity to define and discuss patients' needs and expectations. All of these factors influence the acupuncture dose given at each treatment. Cumulatively, the findings of my study suggest that acupuncture dose should continually adapt and evolve as the acupuncturist gathers and reviews diagnostic information. To support this, acupuncturists would benefit from fostering a professional culture of clinical learning and sharing of clinical practice and research. If we can access this shared knowledge, it will benefit treatments for endometriosis, and ultimately that will benefit our patients.